All right, let's get started here. I'm very happy you guys can all come to Grand Rounds. This is, we do our October Neonatology Grand Rounds as part of the Neonatal Nutrition Conference that takes place the next 2 days. And I always have one of the senior people at the conference come and give Grand Rounds and be a visiting professor. And I'm really pleased this time to have Dave Adamkin here. Dave is an old friend. We go back. We used to attend fellowship conferences together. He's been at Louisville for a long time. He's the director of their nutritional research. He's got an endowed chair in neonatal medicine. He directs the fellowship program. And David is one of these people who has really made the Fetus and Newborn Committee run at the AAP. Both his work in neonatal hypoglycemia, which is what he's going to talk about today, and also in nutritional support and specifically fortification of human milk for preterm babies, are sources that all of us go to inform our practice. Last year we were at a conference together and he gave a version of this talk. And one of the brewing things, and he'll get into this, one of the brewing things in neonatology is, what is hypoglycemia? How do you define it? And like many nutritional things, we have these biomarkers that we use, in this case, a serum glucose. And it doesn't tell you anything about the physiology of the baby itself. It just tells you that you have something above or below some cutoff. So my understanding is the neonatologists and the endocrinologists, and I see we have good representation of both groups here, don't quite see eye to eye on this. So David is here to enlighten us about what is hypoglycemia. We've been arguing about this for 60 years? 60 years. So David's going to solve that for us right now.
Right. Thank you. I got this one. Thank you very much. Well, it's great to be here, and Mike and I do go back a long time. He's a resource for me in nutrition, and it's really a pleasure to be invited to spend a little time with you guys. I think the title of this will make sense as we start to go through it. And let me begin then with my disclosure. And the important one is I am not a neurologist or a developmental pediatrician. My goal is to prevent my patients from needing one, and that's the approach that I'm going to try and take here and share with you the controversies. So I guess we may have a new White House we'll have to pay attention to down the road. So let's start this then with the Pediatric Endocrine Society weighing in on hypoglycemia on a very nice paper that was just published quite recently, where they do share their feelings that there are some issues with the AAP statement, and some of the issues would be around the levels that we're using are too low, that because we're designed for the first 24 hours of life, we're going to miss cases of persistent hypoglycemia. The endocrine approach was to rely on metabolic fuel and hormonal data to establish critical levels of glucose. So neuroendocrine responses and where those occur define the critical levels of glucose. And then their main goal is expedite diagnosis and effective treatment to prevent brain damage from persistent hypoglycemia. So we did work together on this to some extent, and then we're doing our best to mesh the publications, and I'll try to share with you where we are on that as you look at the different references. So these are the papers that I would recommend taking a look at. The one on your left is the recommendations from the Pediatric Endocrine Society, appeared in the Journal of Pediatrics recently. Then the middle one is an editorial that's coming out next month from Rich Poland and myself, trying to address the endocrinologist's concern and try to reach some type of balance between the two. And then the final report is the actual report from the American Academy of Pediatrics Committee on Fetus and Newborn. And you'll see that we didn't know really what hypoglycemia was, so we tried not to use the word. which is very, very difficult. So we ended up calling it postnatal glucose homeostasis in late preterm and term infants, and I think that'll make sense as we develop this story. So we're going to review postnatal glucose homeostasis from fetal to neonatal transitional hypoglycemia. We're going to demonstrate the different strategies used to define normoglycemia and hypoglycemia in the neonate, and then we'll try to evaluate these controversies in screening, diagnosis, and management of low glucose levels. Again, it's very difficult not to say hypoglycemia, and I will say it a few times, but it makes it even more confusing. So the background is it's a relatively common and important disorder. It's most often temporary. Infants of diabetic mothers, premature babies, small for gestational age infants. The long-term concern, obviously, is seizures and permanent brain injury. And it's also very important that we recognize the genetic and non-genetic persistent hypoglycemic disorders. I think that's the main thrust of the Pediatric Endocrine Society, is that we don't miss these cases of persistent hypoglycemia because they're associated with significant morbidity. So let's start then with a simple question, it would seem. What is a normal blood glucose? 20, 30, 36, 40, 45, 47, 50, 60, 55 to 110. All of these have been cited in references or in textbooks as what a normal glucose level is, in the parentheses of the millimoles per liter. Really what we want to know is, when does hypoglycemia cause injury in the newborn? And it's probably related to the level, and it's probably related to the duration of that level. However, we don't really have that answer. And the approach that we took at the Academy was to look at something called operational thresholds, to use the data that was available the best we could and come up with a margin of levels, a range of levels that the practitioner, taking into account other variables, could make a decision as to when they wanted to intervene and how they wanted to intervene. So using a non-disease term is an operational threshold. Well, let's start then with what we've learned about transitional neonatal hypoglycemia. And very elegantly, the pediatric endocrinologists have taught us that this is a transitional neonatal hyperinsulinemia that occurs over the first 48 hours of life. And living in Louisville, this is a picture from the Kentucky Derby that I attended a couple of years ago with Barbara. So let's start with this understanding that the fetal glucose level is different than the maternal glucose level. So here's the fetal glucose level in utero, here's the maternal glucose level. On top of this is data from 2 studies that show us the mean glucose level and then the 95th and the 5th percentiles over the first week of life. And what is clear to understand is the fetal glucose level lasts for about 48 hours. So the glucose level, the mean level, is the first 48 hours of life. After first 48 hours of life, the baby should obtain a level similar to the older child or the adult. One of the disconnects between the PES and the AAP is that we use the lower ranges in our operational thresholds, and the PES used the mean levels to come up with what was considered critical levels for them. This is what postnatal glucose homeostasis is as well, and that babies are born with about 70% of the maternal glucose level, and at about an hour of age, they reach a nadir. And that nadir can be in the neighborhood of 25 to 30 at the 5th to the 10th percentile. That's what we chose to look at. The endocrinologist would use the 50, which would be the mean level of the nadir, falling from 70 to 50 as opposed to falling from 70 to 25 or 30. And what's happening here is insulin levels are actually falling, glucagon levels are surging, and that's what mobilizes glycogen and steadies the baby and prepares the baby for postnatal glucose homeostasis. One of the arguments at the committee was, do you want to sample the nadir? Do you want to sample the first level at an hour of age, or do you want to feed the baby 1 or 2 times before you sample? And that would change things dramatically as far as critical levels and treatment. So we chose the British routine is to feed before screening, not sampling the nadir. Now, we've learned from the endocrinologists in very elegant data that insulin concentrations are high in normal newborns compared to older children and adults. These are levels in millimoles. About 3.5 millimoles is a glucose of about 54. And you see that even at those modest levels of glucose, the term infants still have elevated levels of insulin versus older children and adults. So what we see is that the normal suppression of insulin secretion, which occurs in children at 85, is around 55 to 65 the first 48 hours of life. The first 48 hours of life, and then becomes very similar to the older child or the adult. So this transitional hyperinsulinemia is really unique, the first 48 hours of life. It's also associated early with low ketone levels. The ketone levels are lower than expected in normal newborns during the transitional neonatal hypoglycemia. And the endocrinologist would argue then is that we don't have an alternative fuel for these babies that have low or modest glucose levels. And we'll get into the debate in a few moments about the breastfed baby and elevated ketones as a protective mechanism. The third part of this story is that there appears to be an inappropriate preservation of glycogen in newborn babies the first 48 hours of life who have modest glucose levels. You would think that they would be mobilizing more glycogen when their glucose levels are low, but this data clearly shows that, like the adult, glycogen can be mobilized with epinephrine or glucagon. So as we put this story together, again, very nicely laid out by the Pediatric Endocrine Society, we appreciate the fact that the mean plasma glucose level for suppression of insulin is about 55 to 65 the first 48 hours of life. So there's a unique glucose insulin sensor of the first 48 hours of life. And the lower glucose threshold, this lower glucose threshold for suppression of insulin turns out to be at the same level that neuroendocrine responses are activated in the adult. That means for the endocrinologist, analyzing this from a neuroendocrine standpoint, that's the critical level of glucose, below which there may be danger. We don't agree with that. So this decreased glucose concentrations are associated with decreased lactate, decreased ketones and glycerol, and this large glycemic response to glucagon or epinephrine at inappropriate preservation of glycogen. So this is the story of the first 48 hours. This is a transient hypoglycemia with transient hyperinsulinemia, and we've learned all that. Well, there may be some other reasons why the initial glucose concentration is low. Promotes gluconeogenesis, stimulates appetite for feed-fast cycles, carries over from the fetal environment that facilitates glucose transport from mother to fetus, and all mammals have this first 48 hours of transitional hypoglycemia. So then let's turn this to, how are we going to settle this? What are we going to look at to come, well, we're not going to settle it, but how are we going to look at this by different approaches to looking at levels of glucose? Well, first is epidemiologic data, cross-section data, longitudinal data, looking at levels from many, many, many subjects. The next is clinical, look at what happens to the baby at various levels. The third is the physiologic definition, the one of the neuroendocrine, the one that the PES Society used to come up with the critical level of 55 to 65. And then finally, the one that we relied on to a significant extent at the Academy was to look at a functional definition, to look at neurologic and neurodevelopmental outcome data and try to get a feel for what levels would be associated with an increased risk of injury. Where does neuroglycopenia occur? That's the most important data that we don't have. So let's look at the statistical approach. The majority of babies are above 45 milligrams per deciliter, but a breastfeeding AGA term baby at the 5th percentile has 30 milligrams per deciliter. That is not a baby that you are going to sample. That baby is not an at-risk category, yet that is almost 30 milligrams below the critical threshold for the neuroendocrine neurogenic response. Is that baby not at risk since newborns are not different than adults? However, epidemiologic or statistical approach doesn't define the glucose concentration below which injury occurs, nor does it address the associated conditions that may make the baby more susceptible or more safe. We don't know that. At the end of the day, a statistical norm does not define a biologic norm. So I don't think we're going to get our answer here. Now, here's a meta-analysis of 723 healthy term babies from the literature. And they analyze for the mean, and then they assume the 5th percentile rather than report it specifically for the 723 babies. So it's probably an overestimation at the 5th percentile because the means varied quite a bit. Having said that, you see the mean levels from 1 hour to 72 hours range from 56 to 67. So you really see the new 60 there, don't we? Between 3 hours and 48 hours, the new 60, defining the norm if you're going to use the mean. If you look at the estimate of the 5th percentile, it ranges from 27 at 1 to 2 hours, which is around the nadir, up to around 48 at 3 days of life. Now, in this series, only 1/3 of the babies were breastfed. So this, again, is probably an overestimation of levels. Wide standard deviation we talked about. 10% of the babies were not fed at all before the first level was performed. Here's another study giving us a view of what some people would consider normal levels. Here are AGA term breastfed babies at 4 different ages. We're looking at them at 3, 6, 24, and 72 hours of life. And we see that the mean does hover around 54 milligrams per deciliter. However, the range is between 25 and 144 for term AGA breastfed babies who would not be screened with an at-risk protocol. If we look at the interquartile range, it's 41 to 60. Most of those are below the critical level for the neuroendocrine response. So does that mean all of these breastfed term AGA babies are at some risk? Here's the controversy with breastfeeding, that if one looks at the ketone data, you can interpret it as caloric deprivation, as the Pediatric Endocrine Society does, or you can view it as it rises at 24 hours of ketone levels as protection, as an alternative source of energy. That's the so-called suckling ketogenesis controversy. At the end of the day, it really doesn't matter. Breastfed babies receive about 15 to 20 cc's per kilogram the first day of life of human milk over the first 24 hours. Yet the majority of these babies have absolutely levels that we would consider within an operational threshold normal range. 12 to 14% of AGA breastfed babies, if you use the classic 47 as a normal glucose that's used around the world, and I'll show you where that comes from later, then 12 to 14, 1 out of 7 breastfed babies would be considered hypoglycemic. This is fascinating data that also was brought to light in the PES paper. And if you go back to the 50s and 60s, when babies were fasted, and you look at their glucose levels after an 8-hour, an 18-hour, or a 27-hour fast, their glucose levels are pretty stable in the 50s. So the conclusion from the PES is that when you feed a baby or how often you feed a baby is really not that crucial. I would argue that at the lower levels of glucose, it does matter when you initiate feedings and how often you feed a baby, because we do see a response to feedings. But this is very interesting data to look at when babies were not fed and how they had relatively stable glucose levels at the mean. This is a paper that taught us how many babies are at risk if we use the classic 47 milligrams per deciliter as the critical level. So this is a study from New Zealand, and these are all glucose oxidase. These aren't screening levels at the bedside. These are all performed in the laboratory beginning at an hour of age, and then they did a total of around 3 samples over the first 48 hours of life. So the risk groups are the same as ours: SGA, IDMs, LGA, late preterms, and it turns out about half of those babies will be diagnosed with hypoglycemia if you use this level of 47, which was studied and became the gold standard in the 80s from a nutrition study that I'll tell you about in a moment. So if you play with the numbers here, 25% of all births are from these categories. So 12.5% of all newborns would have a low glucose concentration. That means 500,000 babies a year would be diagnosed with hypoglycemia if we use the level of 47, which is below 55 to 60, which is the critical level for the PES. If I can't teach you anything else today of any virtue, this would be what I would leave you with. The higher the threshold and the more often we screen, asymptomatic babies with low glucose will be identified. And that's the conundrum that we have as we analyze the data. How often are we going to screen them? But more importantly, what are we going to use as the critical level for action? So let's go to the next approach, was the clinical approach. And this is where the classic 40 comes from. It comes from Marvin Kornblath in 1959. So you've heard the new 60. Here's the old 40. Glucose concentration is safe if clinical symptoms associated with hypoglycemia are not observed, or if these symptoms disappear at a specific concentration. Where symptoms occurred was 25, and where they disappeared was 40. And that's where 40 came from. And we use that, some people still use that, for a very long time. This is where that comes from. There's problems with that. Many babies have very low levels of glucose and they look absolutely well. The symptoms associated with hypoglycemia are not specific for hypoglycemia, and we still don't have the other pieces of the puzzle, which are the alternative fuels. There's a lot more that goes into this, as Mike said, than just looking at a glucose value and assuming that tells you everything. It's one piece of the story. The baby's clinical exam is probably much more important than the glucose level. So let's talk about hypoglycemia and brain injury and see what we've learned about that. Again, from the endocrinologist, neurogenic is where autonomic perception of physiologic changes is triggered by hypoglycemia and occurs at about 50 to 60 for the adult. And their position is that the baby is no different than the adult, and that brain glucose utilization is impaired at 50 to 60 milligrams per deciliter of glucose. Neuroglycopenia in the adult is less than 50. Well, we really do not have that level for when newborns become neuroglycopenic. But that's what clearly scares the endocrinologist about the levels that we use in our operational thresholds. What is important is the avoidance and treatment of cerebral energy deficiency. So the signs on this slide would be the ones that we would take most action against and try to prevent and to treat. This is another classic study where I think Dr. Kornblath got his 25 and symptoms from. This is a study from Europe looking at brain injury among babies that had glucose sampled over the first days of life. The babies ranged from 1 kilo to 5 kilos. They got saccharose as their first feeding, first 24 hours. They had 3 glucose levels the first 2 to 4 days of life. 8 babies, N equals 8, if I can get back there. N equals 8. 4 of them had seizures. That's where the 25 comes from. That 25 is where symptoms occur. We didn't know until the 1950s that hypoglycemia was associated with any injury or seizures. And this is the paper that I think is the classic paper where the 25 came from. You also see in this study that they weren't diagnosed until 43 hours of age, the babies that had seizures. Also, the asymptomatics, the controls were no different than the asymptomatic babies. So the conclusion here was that asymptomatic hypoglycemia, regardless of how low the blood glucose, probably does not damage the brain. And that was very important to us in our statement as we approached using the ranges, low ranges, to come up with operational thresholds. So a little bit more about this 1972 study. All the symptomatic babies with seizures had 2 levels less than 20. 2 levels less than 20. Those 4 babies. None of the newborns with only 1 less than 20 had evidence of brain damage. And here's their conclusion in 1972, which is pretty good today. There seems to be no justification for taking an expectant attitude towards neonates with asymptomatic hypoglycemia. It should be detected by a screening system, and if it persists, should be treated to avoid possible brain injury regardless of the absence of symptoms. And that's probably right where we are now, some 43 years later. Now, this is a study that's a modern study, if you will, of brain injury with hypoglycemia. And over a period of 14 years, 35 babies were collected who had symptoms with low glucose levels and did not have any evidence of hypoxic ischemic encephalopathy. So it was a pure hypoglycemia study, if you will. The median glucose was less than 20 for these babies, and they had an early MRI at 6 weeks, by 6 weeks of age, and then neurodevelopmental outcome at 1.5 years. And we see that symptomatic babies with low glucose levels the first 24 hours of life have an increased risk of impairment. 65% of those babies at 1.5 years had injury matter and so on, and clearly had developmental impairment. And this is consistent then with the data from some 25 years before. What was clear was that early MRI findings were more instructive than the severity or duration of hypoglycemia for predicting outcomes. So for babies that get treated and have symptomatic hypoglycemia with seizures should have an MRI early in their course to predict outcome. All right, let's go to the AAP Canadian and English guidelines that prioritize neurodevelopmental outcome to come up with their suggestions. And as you're going to see, we don't agree with them either on the way that they interpreted their neurodevelopmental outcome data to come up with their suggestions. None of this is easy. This is the classic study that 47 took over the world as the critical glucose level. And this was done in the United Kingdom, was part of a nutrition study with 5 centers. And it was a nutrition study that continues today, following these kids who are in their 20s and 30s, looking at the impact of early nutrition on outcome, particularly developmental outcome, and then as surrogates for adult disease as these children got older. These babies were less than 1,850 grams. They're not on our algorithm. Our algorithm starts with late preterm babies. These are babies who are less than 33 or 34 weeks gestation. The majority of them are actually much smaller than that. The mean birth weight was 1,337 grams. We didn't go near those babies because we assumed we had enough trouble with the other groups and that these babies would be in an NICU and somebody would be looking at them. So we provided no guidance for those babies. But this is where 47 came from, so let's see what they did. So babies had a daily glucose while they're in the NICU and until clinically stable the second and third week, and then weekly until discharge. And then they did developmental testing. And what they say is with this observational study, they're going to come up with the critical threshold for hypoglycemia below which babies will develop impairment. It turns out that this was retrospective in nature, so that babies who had very low glucose levels were not treated. They would have a 21 day, and then the next day they'd have a 22, and nothing was done. So as part of the collection of the nutritional data, it turns out that in this study, 2/3 had a glucose less than 47, ranging from 3 to 30 days, and that the relationship was the more days a baby was below 47, the greater the risk of impairment with so-called hypoglycemia. So that's what you see with the days of neonatal hypoglycemia, and then the adjusted risk with those levels less than 47, those number of days. In a letter to the editor, at 7 to 8 years of age for these children, they looked awfully good. So this was a transient phenomenon. And the author admits that this probably wasn't the right way to get this data, that we really needed randomized controlled trials that use different levels, follow babies a long time, and try to answer the question about what a critical level is. However, 47 took hold, and from these premature babies came the application of 47 to breastfed term AGA babies around the world. So what I call this, I trained with Dr. Oski with vagintophobia, I called this quadragenta septum phobia, the fear of 47, which I thought really was not based on any good data. Now I need to turn to my Latin colleagues to find out the fear of 60 to answer the latest recommendations. So let's look at some data that we did use at the AAP and thought it was helpful. This is from Win Tin in the United Kingdom as well, answering his own colleague, but he does a randomized controlled trial, the Neonatal Nursing Initiative, 1990-91. Again, looking at babies less than 32 weeks, not on our study, but certainly of interest to learn what a randomized trial would show. And they looked at daily glucose levels over the first 10 days of life. Index cases were 3 days less than 47. 3 days less than 47, and in the controls, all the levels were greater than 47. So 47 of 566 babies were index cases. Here's a look at 2 years at developmental quotients, and there are no differences at 2 years for the babies that were less than 47 versus those who were not. What's more important, however, is to have long-term data. And they brought the majority of these kids back at 15 years of age and looked at psychometrics, behavior, living adaptive skills, attendance, and health status. And they had information on all but 2 kids. So percent. And they found no differences in the children at 15 to 16 years of age in any of those assessments. So as soon as I opened a journal last week, found a new paper that we needed to discuss here, and this is the Kaiser paper that appeared, or maybe this may be the electronic version, and this is coming out in JAMA Pediatrics. And this is a fascinating study that's going to make this even more interesting. 1998, all infants born at the University of Arkansas had at least 1 recorded glucose the first 3 hours of life. The second glucose was quote unquote normal. What did that mean? They used 3 thresholds as abnormal for the first glucose within the first 3 hours of life. Less than 35, less than 40, less than 45. All the children born that year. So 6.4%, 10.3%, and 19% of babies, respectively, were below 35, 40, or 45 once in the first 3 hours of life. So where this paper is going is a new issue for us, universal glucose screening in the first hours of life. In 2008, they looked at these kids for student achievement scores in the 4th grade. What you're looking at here are the 3 thresholds, 35, 40, and 45, compared to the normal glycemic controls for literacy and for mathematics. So the first bar being the 35, 40, 45 literacy, 35, 40, 45 mathematics. And lo and behold, there was about a 50% reduction in the odds of achieving proficiency in literacy and numeracy at the age of 10 with a glucose level less than 40 in the first 3 hours of life. And the data was similar for 35, not as marked at 45. And important perinatal and sociodemographic risk factors were applied in analyzing this data. So we're back to where we started. Is transition neonatal hypoglycemia a physiologic variation, or is it a marker of inadequate metabolic adaptation? So now the issue, should there be universal screening of glucose in everybody? I apologize for how busy this slide is, but I wanted to get as much of this stuff to you as I could. I made this slide instead of having my wife do it, who really knows how to make slides. So little data on the management of strategies for hypoglycemia in the study. We don't know the rates of breastfeeding. We don't know whether there wasn't recurrent hypoglycemia in this thing because we don't know the glucose levels after the second glucose that was obtained. And all agree that it's unwise yet to instigate universal screening of newborns without further evidence. And what would we do? What would be effective to change these outcomes? Let's do the math on what happened as far as having an opportunity to impact this. The first levels were drawn around 1 to 2 hours of life. The mean was an hour and a half. It took 25 minutes to get the sample back. You're now 2 hours of age. Then you do something about it. You feed the baby, or you IV the baby. They didn't know that in the study because it was retrospective. Then you're at now 75 minutes later to see what happened in follow-up. You're at 4 hours of age. What can you do to decrease the exposure to hypoglycemia if this really is hypoglycemia? So it's very unlikely we're going to have any intervention after the first screen that's going to change the experience of that baby. Perhaps this might be a marker for something else that occurred in utero and not related specifically to the hypoglycemia. But stay tuned, because this is very new and very, very interesting. Well, let's go back to where we started with operational thresholds. Blood glucose concentration, that's not where the game ends. There's a lot of other things we want to know. What are the alternate fuels? What's the ketone situation? Even the adaptability of the local circulation is plays here. You're ill, you're going to be more susceptible to injury from a low glucose level than a baby that's well. So those come into play. So given the complexity of all of this, a concept of a rigid threshold for a blood glucose is challenged. And in our statement, we went out of our way for the plaintiff bar to say that there is no data that suggests one low glucose level is associated with poor outcome later. That just doesn't exist scientifically, yet it's used all the time legally. So the clinical exam is more important than the glucose level. Well, let's look at some other advice from the Pediatric Endocrine Society. Because babies commonly have low levels of first 40 hours of life, it's going to be difficult to identify a persistent hypoglycemia disorder during that time. And that's absolutely right. And that may be one of the mistakes of our paper was we didn't stress that enough, that we're a 24-hour guide. We're an algorithm for the first 24 hours. We didn't address the rest of the first week of life in those babies. And finally, I guess where our debate remains is the 55 to 65 and the neuroendocrine response is defining what should be the critical level for glucose. Endocrine Society, who to investigate for persistent hypoglycemia. Any baby that's had severe hypoglycemia requiring intravenous therapy or actual symptoms should be investigated as they recover, after their recovery. Neonates unable to maintain a pre-prandial glucose greater than 50 by day 3 need to be studied. And that one's going to cause issues in the well baby nursery with discharge and so on, but even in the NICU, we need to pay attention to that. Then I think the other lists are pretty easy. The key is hypoglycemia must be recognized as an inpatient, not an outpatient. The endocrinologists are absolutely correct. So let me show you practically what I did on the committee. Got a lot of people running in the other direction as we were trying to put this together. So these dogs really did it for me. The dog that's sniffing is looking for evidence. The dog that's being sniffed is looking for guidance. So can you provide guidance where you don't have all of the evidence? And I think that was the debate, and we had some people know a lot more about this than I do who thought we shouldn't do this, that we shouldn't do an algorithm because there wasn't enough science. But I'm also in Kentucky, where I know a physician in Possum Trot, Kentucky, who gets a 5-kilogram baby, probably should screen that baby for glucose and needs some guidance. We know enough that that should be done. So that was kind of the conundrum in trying to decide whether we move forward on this. So what's the operational threshold? It means that a plasma glucose at which a clinician may consider appropriate intervention for infants judged to be at risk. We hope it's flexible with a margin of safety, and it takes into account not just the plasma glucose, but what other risk factors there are, the clinical state of the baby, continuous variables. For the lawyers, it does not denote a plasma glucose universally indicative of neurologic dysfunction or injury. So what does it begin to look like? It's very similar to the bilirubin nomogram, where we take certain features of the baby's condition, data, put it together, make a decision about action. So these are the 4 key observations that were used in developing the AAP algorithm. That most babies with proven symptomatic neonatal hypoglycemia are around 20 to 25 in the first hours of life. That persistent or recurrent syndromes present with equally low plasma glucose concentrations. Little or no evidence until yesterday existed that asymptomatic neonatal hypoglycemia at any concentration the first days of life results in any adverse sequelae in growth or neurologic development, and we hope that this provided a large margin of safety associated with development of clinical signs. So this is our algorithm. We divided it into 2 sections. The first section, the birth to 4 hours, is transition. 4 to 24 hours of glucose should be coming up. So what you see is that babies should be fed within 1 hour, consistent with the WHO, and then the baby is screened 30 minutes after the first feed. The first critical level, I guess, is 25. Less than 25, the baby should be fed again. It's asymptomatic. Check in 1 hour. Still below 25, treatment recommended. What's the operational threshold in the first 4 hours? 25 to 40. You decide. You decide. You want to feed it? You want IV fluids? That's your operational threshold. People wrote me letters. Why didn't you tell us what level to treat them at? I got letters that you're screening too much. I got a lot of letters about this. Then the second block is the 4 to 24 hours. And again, you're feeding every 2 to 3 hours. The screen is less than 35. It's potentially actionable. If it stays below 35, IV fluids, your operational threshold is 35 to 45. And we'd like the target glucose to be above 45 prior to feeds. So we're not that different than the endocrinologists as you think as you start to mull this over. Obviously, the top of the algorithm are the babies that are screened. From old data, we used the 12 hours versus 24 hours, depending on whether the baby was a late preterm or SGA. They're screened longer. The IDMs and LGAs are screened shorter for 12 hours versus 24 hours. Any baby that's symptomatic, you get the bedside glucose and you go. You treat that baby. And then you confirm with the plasma glucose. But you don't wait for the plasma glucose. You got a low screen, symptomatic baby, you treat that baby and then wait for the confirmatory plasma. Here's some conclusions that I think put this, into proper perspective. There's little consensus on the significance of transient and asymptomatic hypoglycemia. Most data indicate that adverse outcomes do not occur with such conditions. Transient asymptomatic, however, may herald metabolic disorders that do cause injury. So we can't send these babies home until we're certain that they're able to go through feed-fast cycles and maintain an acceptable glucose. As with normal infants, there's no evidence that treating transient, asymptomatic low glucose improves outcome in IDMs, late preterms, or small and large infants. So the Pediatric Endocrine Society recommendations that feed should maintain a glucose greater than 50 the first 48 hours of life. We should maintain greater than 70 for those requiring IV fluids. And then after 48 hours, a newborn baby should have glucose levels greater than 70. And I think this is the one that some folks are still struggling with in the NICU. For those babies who need further investigation, this is the 6-hour fast that we've begun to embrace as well. You do a bedside screen at 3, 4, and 5 hours. You do the plasma glucose at 6 hours, and if the baby's less than 50, that baby goes on to the full endocrinologic evaluation. I can tell you the parents are not fond of 6-hour fasts in newborn babies, but I think this is something we need to consider. There's an app for this. This is the sugar wheel. I think we get $2, and we haven't sold any, but it's on, you probably don't like this one. I like the one my wife designed, but my co-author wanted to run with this one. So take-home points. No guideline is perfect. Individual patient characteristics are important. Clinical judgment is critical. Practical. Normative data for glucose concentrations the first 40 hours of life cannot be extrapolated to older newborns. Throw away the 35 to 45 after the first 48 hours. It changes. You saw the maternal and the glucose set points. The glucose concentration without all the other stuff is not useful. A low glucose concentration is not a diagnosis. Take extra care at time of discharge, presumptive versus confirmation, being sure you've evaluated that baby to make sure that baby holds his glucose where it needs to be, and documentation and communication. Now, for all my Gopher fans, let me see if I can get this to play. This is 2 weeks ago in Columbus, Ohio, with my granddaughter and one of my daughters. Urban Meyer, Ezekiel Elliott. All right, thank you very much.
I was going to say, there's got to be a lot of questions. David, thank you so much for that.
My pleasure.
This is an admittedly naive question. I enjoyed very much what you had to say, but are there any data from mammals at the cellular level with these various concentrations in the milieu? They'd have to be obviously probably in vitro studies.
Right. One of the methods that was tried to be used was looking at EEGs during these low glucose levels and to use those to demonstrate brain function. The problem is they weren't very sensitive, and the guidance they provided at this point was not practical. But I think that's where the answers are going to come from for sure. It's not going to be all these epidemiologic studies with numbers that we don't know what to do with the outcomes.
So if they took, cells from neonatal whatever kind of mammals, because you said that they all behave similar, mammals behave similarly, can you, by studying the cells, see any influence on cellular metabolism at the various levels?
You do at the low levels. There's neuroglycopenia for that particular model that you're using. Again, translating that to term AGA breastfed baby then becomes much more difficult to make that leap. But I think you're exactly right. That's where we're going to get this from.
I've been working on this with my rat models, which are obviously not the perfect model for the human equivalents. And we can look at the cerebral energy metabolism in vivo using high-field NMR spectroscopy and using the same target value, less than 40. We know that the animal can maintain brain energy metabolism for at least 4 hours before actually ending up with energy failure and then go on to develop cell death and so on. And I think there is also some data from Jane Harding's group that they had continuous glucose monitoring, and they also had evidence, they had continuous AEEG monitoring. And some of these babies, the group that we are talking about, the late preterm and IDMs, they had blood sugar values below the 2.5 millimoles or 47 for as long as 6 hours without having any changes in the AEEG. So again, looking at the Arkansas data, I don't know how much we can give value to a single value without knowing what happened later. And I think the closest mammal to the humans being monkeys, there are some data suggesting that they can have low values for up to 12 hours and not have any brain injury on follow-up.
The transcutaneous glucose interstitial sampling is fascinating because the one study I showed you, less than 47, they did that, and I didn't get to show that slide. They missed, with intermittent sampling, you miss 81% of episodes below 47 if you do transcutaneous monitoring. So these babies are down there for most of that first 8 to 12 hours of life that they're going to dip. And that's the problem with transcutaneous. You get 1,000 values, you don't know what to do with them. Well, SATs, yeah.
From one of the endocrinologists in the group, I wanted to thank you for.
I was nice, wasn't I?
You were great, actually. I've attended a few of the lectures about this controversy at our PES meetings and worked with Paul Thornton, taking care of some of the children who have the hyperinsulinism challenges that are missed if we don't catch them early. And so I wanted to ask you if the operationalizing the 6-hour fast, how has it been accepted in the neonatal communities? It's new, it's different. What do you think is coming?
Yeah. I think it's early yet. I don't know that it's been embraced by the majority yet. Because I'm following this pretty closely, we do it. We try to do it. I think the key here, and the PES is absolutely right. We have to make as many of these diagnoses as we can, as soon as we can, because the morbidity is tremendous. The problem is one of the syndromes that I wasn't even aware of, and now I look for every day, is this persistent stress hyperinsulinemia, which is associated with C-sections, meconium-stained fluid, abnormal fetal tracing, C-sections. So the endocrine statement wants us to sample all of those babies. So now your samples would probably go to 1 million babies. And how much fetal distress gets you screened? How much meconium gets you screened? But where they're going is that we may be missing cases of this persistent stress hyperinsulinemia, which is very responsive to diazoxide and goes away. But I've looked for those cases, and I think we need to become more sensitive to making that diagnosis as well. So I think we should be doing the fast. I think we do need to pay more attention and make sure that any baby that we've treated for hypoglycemia, you make certain that that baby has normalized prior to going home.
Thank you.
So I'm curious of any of the pediatricians who are out in the normal newborn nursery, how they feel about that.
That's a problem.
Separation of the baby. Neonatologists are happy to keep their units open, and this is a good way to guarantee that. And Dr. Negle would probably be very happy with all the NICU admissions, but doesn't really serve the baby all that well.
Well, there's actually some experience there as well. I won't name the hospital or where it is, but there was about a 25% increase in admissions when they adapted the higher levels and actually made it in Facebook among mothers. Don't go deliver there because your baby's going to end up separated from you and not breastfeeding with you, because many, many babies are having diagnosis of hypoglycemia made. So it's a real problem, and particularly this Arkansas data really is a whole different thing. It's universal screening for everybody. It's a whole different topic.
So one of the things that you did not touch upon is the what will happen if you suddenly increase the blood sugar of a baby that had been low. Because there are some data suggesting that maybe it is the fluctuating glucose that is more detrimental than either very low or very high. And if you are giving this kind of IV dextrose and suddenly increase the blood sugar value, you probably are creating some oxidative stress and further damage that way. Any comments on that?
Well, I mean, that's just from the transcutaneous monitoring to even have an appreciation of that. When you do intermittent sampling, you only see that sample at that interval. I think the dextrose gel is a new therapy that could keep us steadier with the levels, as you're suggesting. We have a neat program at one hospital where we actually have syringes of donor milk in 10 cc syringes that we give breastfeeding babies who you want to supplement. I just heard that you can lose your baby-friendly designation if you supplement with formula for hypoglycemia. So it's a real mess. I don't know about the fluctuating levels. I don't have a feel for that. But it would make sense that physiologically that could be harmful to fluctuate like that.
We do have the dextrose gel in our protocol.
Good. Yeah, we don't have it yet. We're working on it. I think that's the way to go.
I'm just curious what's known about what happens at 48 hours. Like the set point or the sensor changes. Is it understood mechanistically what's going on to change
thanks
that?
for bringing that up, because this is another fascinoma in this to me. This first 48 hours of life is exactly mimicking a congenital defect of glucokinase. In other words, that defect is associated with a lower set point for suppression of insulin. So what's being suggested is that all newborn babies have this mimicking of a genetic congenital defect of metabolism the first 48 hours of life, and then it goes away. So, the glucose insulin sensor changes at 48 hours, and the maternal set point becomes more like the adult set point. That's about all I can tell you about it. I mean, that's what happens.
There are a number of things that do that in the neonatal period, including calcium metabolism and even later chemoreceptors to CO2 and so on. So perhaps just a developmental delay. But it does beg kind of the question of, why you would have a system that would take that long to adapt. I know you didn't design the system.
No, I like the system. I think it's there for a reason. We just haven't figured it out yet, like bilirubin. Why a baby's jaundiced the first 48 hours. It's an antioxidant. Maybe it's supposed to happen. If you look at reptiles and birds, they don't go to bilirubin. They stop at the metabolite before because it's not toxic. They don't make bilirubin.
Do you think this
They
is
stop at biliverdin, which is a non-toxic pigment.
Do you think this is a problem of goals versus expectations? So, you can, we do this obviously in finances in the department all the time, or academic goals or whatever. The PES might be talking about one, the AAP may be talking about the other, in terms of level.
I think the PES is totally vested in stopping congenital hyperinsulinism genetic cases that go home and come back with such poor outcomes. I think that's where they're coming from in that process, and their reasoning, which is valid. They came up with the 55 to 60. I think that's all that this is about.
Brandon, you're going to get every endocrinologist in the audience.
My best friend is a pediatric endocrinologist.
Nice. Yeah, I feel like I have to come clean and say that I'm an endocrinologist as well. I think at the crux of this question is that this finding of low glucose levels and how low those are, it's a statistical definition, right? So we're looking at what percentage of kids are below this threshold. And anytime that you're looking in that group, whether that's the 2 standard deviations below the mean, so to speak, many of those individuals are normal. However, some of those individuals are going to have some type of genetic abnormality, and this is similar to almost every diagnosis that we follow in many different disciplines, right? You're looking at those individuals that are outside of the norms for the lab value. So I think moving forward, identifying the most or highest risk factors. So identifying these kids that maybe we should be looking at particular elements of their history, exam, family history, maybe other biomarkers that would tell us that they are perhaps one of the congenital hyperinsulinism cases, or one of the other high-risk situations is going to be one of the most important pieces for us moving forward in trying to determine who and when we should be evaluating some of these kids.
I would agree with you, just with the exception that we don't have the data that a 27 at 2 hours of age is more likely to develop one of those syndromes. What we do know is that symptomatic babies absolutely need to be scrutinized. Our problem is, do they become symptomatic after they go home? That's the problem. So our best case is recognize the babies with modest levels that don't have any other risk factors and really hone in on them. I think, and SGA babies are also in that pool of persistent stress hyperinsulinemia. So they're not even hypoglycemic because they have absent glycogen, they're hypoglycemic because they have elevated insulin levels, the SGA babies.
Any other questions? Well, David, thank you very much.
Thank you very much.